So in the RAS mutated patients, we have two options now. We have regorafenib and TAS-102. So we have a third line and a fourth line. And the question is, how do you sequence those agents? Which one comes first? We have used regorafenib in the third line setting for our patients until TAS-102 was approved, and TAS-102 found its natural placement in the fourth line, although you can argue for some patients, select group of patients, you may use TAS-102 in the third line first. And those are the patients, for example, who may have issues with liver dysfunction, as long as they're not severe, but concerning for regorafenib start, because again, if they're severe, you can't even use TAS-102. Patients who have some residual issues with hand and foot syndrome, and these are rare patients with capecitabine and fluoropyrimidines. On the other hand, if a patient has had a lot of chemotherapy and issues with chemotherapy with maintaining their blood counts and their platelet counts, their white count, and anemia, then TAS-102 can induce some significant neutropenia in some patients, even febrile neutropenia in about 4% of the patients. So TAS-102 may not be favored in that setting. And so there are certain groups of patients where you can think about sequencing, but naturally, right now, the way the studies were done and the natural entry into the clinic, it's 2 lines of chemotherapy plus bevacizumab for the RAS mutated patients, regorafenib, and then TAS-102.